Can everyone hear me okay? So good afternoon. Thank you for joining us, taking out time from your weekend. When I was invited to give a talk for our symposium, I was trying to think what would be a relevant topic which can raise awareness. And especially as an endocrinologist, I've often wondered about the prevention aspect of chronic diseases. And for me, as an endocrinologist, diabetes is one of the most common chronic diseases. So by the time a patient comes to see me, they've had diabetes for decades, right? And I often wonder if there is a way we can prevent this chronic disease. And so that's the reason the intention behind the talk is to raise awareness. And the answer is absolutely yes. We can prevent type 2 diabetes. And then I wanted to take this opportunity to talk about continuous glucose monitors. So this is a tool which has been revolutionary in the management of our diabetics because it gives you real-time blood glucose data. But I have been using this a lot and recommending a lot for my pre-diabetic patients as well. And then we also have now data which shows that even healthy individuals can really benefit from this technology. So I'll take the next 40 to 45 minutes to go over the prevention aspect and then talk about the continuous glucose monitors, and then I'll be happy to take questions in the end. So let's start with the statistics so that we all understand how big chronic disease burden diabetes is. So we have around 38.4 million people who have diabetes in the United States. And these figures are most recent in the last 2 years. Out of that percentage, 29.7 have a clinical diagnosis. And there are 8.7 million people who are walking around unaware, undiagnosed. But even more important than that is that there are around 97.6 million adults who have pre-diabetes, and big percentage of them don't even know, right? So it's well known that diabetes is a major contributing factor to cardiovascular disease and death. It's the #1 cause for blindness in the United States, #1 cause for end-stage renal disease, also #1 cause for non-traumatic amputations. And if we look at the healthcare budget in 2022, the estimated cost for diagnosed diabetics in the United States was $412 billion. So if we talk about prevention, we can greatly reduce this chronic disease burden. Okay, so before anybody develops diabetes, there is this whole trajectory of decades of having insulin resistance, which then goes into pre-diabetes, and then you become a diabetic. So what is insulin resistance, right? Because that's where we start. That's the basics to understand if we are talking about prevention. So basically, insulin resistance is it's an impaired biological response to insulin stimulation of target tissues, primarily your liver and your skeletal muscles. So the figure on the top shows that when we eat, our stomach, food is absorbed and glucose is released from the food into the bloodstream. And then your pancreas, which is the organ which produces insulin, so pancreas have cells called as beta cells, and they are the cells which release insulin. So in response to your food, which causes elevation in blood sugar, which is normal, your pancreas work, they release insulin, and then the same mechanism goes, and it goes to your liver where your glucose is stored. It is used for multiple mechanisms, for energy production, for other pathways, and also used at the level of the muscle for energy output. So technically, there is no elevation of glucose in the blood. So there is normal level of glucose in the blood because whatever glucose was released, insulin was released from the pancreas, it's being utilized by the muscle, stored in the liver. That's a healthy individual, right? Now, patients who have insulin resistance, what happens is there is glucose and insulin release simultaneously, but liver is resistant to the action of that glucose. So it doesn't end up taking enough glucose, so it's spilled in the blood. Your muscles are resistant to the action of the glucose, so it is not taken in that percentage where it can be used to output for energy. So that excess glucose then spills in the blood and your blood glucose rises. So that is the initial aspect of insulin resistance. And then over time, as the resistance increases, there is more spillover in the glucose, and that's how diabetes develops. So this figure I wanted to sort of show to understand that it's by the time you develop diabetes, so you'll have impaired glucose tolerance where your blood sugars are going to be elevated, but not enough to have a diagnosis of diabetes, but you could be a pre-diabetic. And then the side is the normal individual. So the red line shows insulin resistance, and as we can clearly see, the insulin resistance starts rising progressively, and by the time you're a type 2 diabetic, it's at its maximum. And then I wanted to show the yellow line, which is the insulin production. So insulin production is from the pancreas, from the beta cells. And as we see that when our insulin resistance is rising and our glucose level is rising, our pancreas are working harder. They're releasing this insulin to make sure that the blood glucose remains normal. So they are overworked, and by the time you have prediabetes, which is this impaired glucose tolerance, they're performing at their peak. So technically, when you develop type 2 diabetes, the beta cell function is markedly reduced. And this slide basically shows us, again, the percentage of decrease in beta cell function. So to make it simple, this is the time the 0 is the time when you're diagnosed with diabetes. And you can see that you could have impaired glucose tolerance or high blood sugar as far as 15 to 20 years prior to the development of diagnosis of diabetes. But even more important than that is if you look at the beta cell function, so the broken line is the beta cell function, and you'll see that if you've had pre-diabetes for like 10 years, your beta cell function is down by already 40%. And once beta cell they're lost, they're forever lost. You cannot recover unless you have a pancreatic transplant. And by the time you're diagnosed around, which is 0.0, 50% of your beta cells are burnt out. So it's important to understand that if we are talking about the prevention aspect of diabetes, how do we preserve beta cell function early on so it doesn't get destroyed and we're able to prevent this disease? And the only way to do that is to make sure we are not having elevated blood glucose and insulin levels. So this slide shows the same, just to make it simple. Prediabetes is approximately 40% loss of beta cell function, and then by the time you develop type 2 diabetes, the loss is around 60%. So then let's talk about if somebody is healthy individual is walking around, are there any clinical features or manifestations we can see which suggest towards insulin resistance, right? So if somebody has darkening around the nape of the neck, or sides of the neck, in their armpits, there is a medical term called as acanthosis nigricans. That is totally associated with insulin resistance. So then you also can see some skin tags in that area. So if somebody has that, they should definitely get tested for prediabetes and insulin resistance. Also, a lot of females who are in the reproductive age group, if they have irregular menstrual cycles, they have acne, they have abnormal coarse hair growth affecting their chin, upper abdomen, they should be screened for an endocrine condition called as polycystic ovarian syndrome, which is associated with insulin resistance and then risk of developing diabetes in their lifetime. So those are some of the clinical manifestations. So technically, who all should be screened? If in a normal population, who should be screened? So anybody who is overweight or obese, so if they have a BMI which is greater than or equal to 25 or greater than or equal to 23, and if they have any of the following risk factors, like if they have first-degree relatives with diabetes, if they have a high-risk race like African American population, Native American, Asian American, if they have history of cardiovascular disease, if they have hypertension, if they have a low HDL. So HDL is your good cholesterol, LDL is your bad cholesterol. So if you have a lower HDL, that is a risk factor. And triglycerides, for sure, if you have an elevated triglyceride, especially above 250, because the normal is you want to maintain it below 150, that's one of the precursors for insulin resistance. So a lot of my patients who come see me for weight loss, I always make sure there is a lipid panel, because if their triglycerides are high, I know that they have insulin resistance. Then again, as I mentioned, if you have history of PCOS, if you don't exercise, you're physically inactive. If you have history of gestational diabetes, because we know that there's risk of developing diabetes in your lifetime if somebody's had gestational diabetes, which is when they're pregnant. And then also patients who have HIV, or if you're 35 years and older. So basically, everybody should be screened, in my opinion. If you're 35 and above, make sure you get a screening. Okay, so what are the cutoffs? What are the numbers we should be looking at, right? So when we talk about diabetes, we know, so FPG is fasting plasma glucose. So if you have a fasting plasma glucose more than 126, more than equal to 126, and an A1C more than equal to 6.5, you are a diabetic. If that fasting plasma glucose is between 100 to 125, or your A1C is between 5.7 to 6.4, that's pre-diabetes. And then a normal individual will usually have a fasting plasma glucose less than 100 and an A1C less than 5.7. So that is your normal category. So this graph basically shows us the percentage year risk of developing diabetes from pre-diabetes. So by the time your A1C is around 5.7 to 6, your 5-year risk of developing diabetes is around 25%. By the time your A1C is around 6 to 6.4, your 5-year risk of developing diabetes is as high as 50%. So how do we prevent? So the most important aspect is diet and exercise, lifestyle changes, right? Now, when it comes to diet, before I end the talk, I'll have, we have a slide on Braden Diabetes Center, which is our center in Green Bay, where we do a lot of education for our diabetics, pre-diabetics. So diet is very, very important, which would meaning you have a carb-controlled, healthy diet where you have more of complex carbs, eliminate simple carbs like white bread, white pasta, because they really cause spikes in blood sugars. You should see a diabetes educator or a registered dietitian or a nutritionist, and they can go over all the details. And then exercise is a must, because exercise, we know, has been known for decades, reduces blood sugars. And it's advised to have at least 30 to 60 minutes of moderate intensity exercise. So what is moderate intensity? Moderate intensity would be brisk walking, not slow walking, a little brisk. If somebody's physically active at home and they're, vacuuming, mopping, that also will elevate your heart rate, so technically that also counts. If you are fond of mowing the lawn, sure, that is moderate. Somebody who likes to play a sport like tennis, bicycling, all that goes into the moderate category. So moderate is recommended, 30 to 60 minutes at least, couple days a week. Okay, so as I mentioned, we already know the fasting plasma glucose cutoff, the A1C cutoff. The other way to diagnose is to do something called as 2-hour OGTT, which is the oral glucose tolerance test. So you are given a 75-gram drink, which doesn't taste that good, I will admit. But you ingest that, and then they do a plasma sample, they draw blood, and they look for the blood glucose. And if your blood glucose falls between 140 to 199 2 hours after that drink, then you're a pre-diabetic. And if you're above 200, then you're a diabetic. So that's another measure for measurement of the pre-diabetes. Sorry for the slide, it's a little condensed because I couldn't find a better way to put it, but you could go on to the American Diabetes Association website. And they have this calculator, which I found really neat, which can tell you your risk of having type 2 diabetes. So it'll ask you questions like, what is your age, your gender, if you've had any gestational diabetes, if you have any family history, if you've ever been diagnosed with high blood pressure, if you're physically active or not, and then your weight. And then it gives you the score at the bottom. And if you have a score of 5 or more, then you are at risk. Then you should definitely talk to your provider and get appropriate testing. Okay, so what are the major players? So major players, as I said, lifestyle, diet, exercise. If somebody smokes, then highly recommend cessation of smoking, because that obviously plays a role. Adequate sleep, because when we are sleep deprived, we are more stressed. Stress releases. If you're stressed out, you have cortisol elevation, it's hormonal, your blood sugars rise. And then you have the genetic component, right? A lot of, if it runs in your family, that plays in the role. And then there are certain medications which can also predispose you to developing diabetes. For example, if you've been on steroids for a long period of time, that is one of the risk factors. So in summary, the recommendations for prevention would be get annual screening with your provider. If you're overweight, you haven't been able to lose weight, in spite of we have a lot of drugs in the market which help with weight loss. Metabolic surgery is one option, although I reserve it as the end stage, last resort. It's never my first preference. Then obviously exercise, nutrition, cessation of smoking. And then if you've tried everything, nothing is helping, then drugs like metformin. I use metformin a lot. It's one of the oldest, most effective drug in reducing insulin resistance. So you could totally be on a medication like metformin. So I wanted to take this opportunity to sort of understand or make you guys aware that if, for example, you go to your provider and you have a fasting glucose and you have an A1C and it's both normal, so does that mean that you don't have to worry? Well, the actual answer is no. There are other parameters to look for if we are talking about insulin resistance, if we want to talk about the prevention and catching these markers early on. So in order to understand that, one of the main markers is your post-meal blood sugar. So when you eat, if there is a blood sugar spike, then that is one of the most important markers for insulin resistance and your risk for developing prediabetes and diabetes. And that's where continuous glucose monitors have been a game changer, because they look at your real-time blood glucose data, because you wear them you wear them from 7, 10, or 14 days, depending upon which CGM you choose. And they'll show you what sleep is doing to your blood sugar, what food is doing to your blood sugar. So let's start with understanding what is a continuous glucose monitor. So a CGM basically is a device. It goes on. Yes.
Can I ask one quick question, please?
Yeah.
Before you go to, is the monitor considered DME? And would you expect it to, under the changes under our new federal guidelines, with the likes of Dr. Oz in charge, to approve it for anyone with an A1C less than 8?
So it's.
Repeat the question.
Yeah, the question is this DME? Means, is it covered under your durable medical supplies, right? And under current law, do you see it being approved for non-diabetics? Is that correct? That's the question? Okay, you're welcome. So it's DME only for diabetics types, and it depends if you are on, so Medicare has different guidelines, but there are two companies, Dexcom and Abbott. They released an over-the-counter CGM, which I'm going to talk about just shortly, where you don't need a prescription. You just go online, order it. You don't have to go through the insurance route. So there are options now. Okay, so what is a continuous glucose monitor? So basically, it's a sensor which goes on your arm or your abdomen, and it measures your glucose every 1 to 5 minutes, and it transfers the signal you have a receiver, or you can download an app on your phone, and you'll be able to look at your blood glucose every 5 to 15 minutes. So it includes 3 components. So basically, when the sensor goes on, there is a small filament, which is like less than 0.4 millimeters thick, and it measures your interstitial blood glucose. And that's how it's showing you the reading on the phone or on the receiver, which is your blood glucose. Now, it's important to understand that there is a difference between the interstitial blood glucose and a finger stick. So whenever we prick our fingers, that particular reading we get is from the capillary blood, which is way down there. So there is usually a delay between the finger stick and the continuous glucose monitor reading. The finger stick is the most accurate. For example, you check your finger stick and it reads 100. And your CGM or your continuous glucose monitor is reading, say, 90. So it will catch up to the 100 in 20 to 25 minutes. So there is that delay, and the delay is because your CGM is measuring interstitial glucose, and your finger stick is the capillary blood. So this graph basically shows us how important a tool, a continuous glucose monitor is. So if you look at the black dots, those are, say we use those as finger stick data. So for example, a patient's like, okay, I'm checking my fingers, I'm doing my finger sticks 3 times a day. My morning blood sugar, so the first dot, say his fasting is like 90, right? Then he checks again before breakfast and say it's like, or after breakfast, and it's like, 150. And then before dinner is 100. So in his head, he's like, I'm checking my blood sugars. My numbers are looking okay. But if you look at, if he was to wear a continuous glucose monitor, you'll see he had a spike after breakfast, which touched almost 350. This spike would not have been picked up if he didn't have a CGM. So finger sticks will only give you sparse data during the day. It doesn't give you 24/7 pattern of blood glucose, which is where a continuous glucose monitor comes into view, because you have more data points to compare. So a perfect example how to make this more easy to understand is that when we talk, and I tell this to all my patients, like A1C doesn't give us the complete picture. It's only one part of your lab value, because I always look at the continuous glucose monitor data, right? So for example, the last figure, which shows 100% time in range, so this is patient number 3. So patient number 3 has A1C of 7. And if you look at the green region, that is the target range. So for diabetics, we want to keep the blood glucose between 70 to 180. And if you see, 100% of the time, this patient had time in range. So this is one of my ideal diabetics, right? So that's patient number 3. If you go to patient number 2 right in the middle, his time in range was only 70%. Why? Because he had some glucose excursions after meals. But A1C is still 7. And if you look at patient number 1, his time in range is only 40, because he had highs and he had lows. So for me, the ideal patient would be patient number 3, because his is the least variable blood glucose. So when we talk about ideal control, we want to make sure we don't have the peaks and we don't have the troughs. So that is where a CGM totally is game changer, because you have much more data to see how your blood sugar is being affected throughout the day. So as we mentioned, CGM, it gives you real-time data. You have, for our diabetics, they get alerts. If they're having low, they're having high. So it's been really great. So these are some of the personal CGM options, which are prescription. You need a prescription. So these are more reserved for the diabetic population. You have the Freestyles. You have the Dexcom. You have the implantable Eversense, which you could use up to 1 year. And then you have the other ones like Guardian and Simplera, which are used for insulin pump patients. But I wanted to focus on the non-prescription options, because we are talking about prevention, right? So we're talking about, can healthy individuals use this? Can our pre-diabetics use this? So yes, so as I had mentioned, you have 2 companies, Dexcom and Abbott. They released Dexcom last year. Abbott earlier this year, released 2 over-the-counter continuous glucose monitor by the name of Stelo and Lingo. you can just go to their website and you can order that. Do not need a prescription. So the Stelo, which is by Dexcom, you change, it's basically approved for people who are 18 and above and those who don't take insulin. So basically are pre-diabetic and even healthy individuals can wear it. So the sensor measures glucose every 15 minutes and it has a 30-minute warm-up. So when you put it on, it takes 30 minutes to warm up and then it starts giving you your blood glucose reading. The range is from 70 to 250, so you can change that range. And I'll talk about that range in the slides ahead. That range is movable. So basically what you do is you download this app, Dexcom app or Clarity on your phone, and you can look at your blood glucose 24/7. And it also will show you the spike detection. So if you have a high blood glucose after you eat, you'll be able to see that. And it has an in-app learning, which tells you if you go to certain in-app features, it will tell you, okay, if your what sleep does to your blood sugar. So for example, if you didn't have a good night's sleep, what stress will do, what exercise does, what food does. So it's very informative for patients because then it explains what our target range is. So it's very self-educational, so gives you a lot of data points to work with. And then you have the Lingo from Abbott. Again, indication is for people 18 and above who are not on insulin. The range for this is wider. It's 55 to 200. You can change that, and it updates every minute instead of every 5. But it has a 1-hour warm-up period, so it takes an hour before you start reading the blood glucose on your phone or on the receiver if you decide. It also has an app. The only difference for the without prescription CGM, the Stelo and the Lingo, is it will not alarm you. So if you have a high and if you have a low, it's not going to give you an alarm, which I think is great because sometimes you have a lot of the alarms and maybe your spouse will be really angry if they're waking up in the middle of the night. I have so many patients who tell me, I hate this app, I want to throw it out because it disturbs my sleep. So there are no alerts. So I think that's beneficial because you don't expect non-diabetics or healthy individuals or pre-diabetics to have too many spikes. Okay, so the difference between these two is the Stelo is good for 15 and a half days. So one sensor lasts you 15 and a half days. Abbott is only 14 days. And Dexcom has the added benefit of being able to share data. So you could share it with a loved one, with a friend. If somebody, are you trying to compare your blood glucoses? You have a buddy you want to talk about, you have that option. Abbott doesn't have that. As I mentioned, the glucose range for both is comparable mostly. Dexcom will give you real-time alerts. So if you have too high a blood sugar and you choose that alert, it'll give you an alert if you go too high. That feature is not available for Abbott, unfortunately. And then you have the education within the app. Both have in-app learning. Both have, like Lingo has Lingo points. So you want to make sure you have the least amount of points because they'll give you a point if your blood sugar rises above a certain level, then they'll give you what you could have done to prevent that rise. So it's pretty educational. Okay, so it's important to understand that there will be falsely high and there could be actually, not will be, there could be false high or low readings on the continuous glucose monitor. So if you are taking high doses of vitamin C, anything above 1,000 milligrams, that needs to be, it can interfere with the readings and gives rise to false high. If you're on acetaminophen, like more than 4 grams a day, that can impact the reading. If you're on tetracycline antibiotics, then there is a CGM called as Eversense, which is 1-year one, which can affect the two most common ones, the Dexcom and the Libre, do not get affected. And if you are on high doses of salicylic acid, you can have a falsely low reading on the CGM. So that is not accurate, so something to keep in mind. Now, something which is very commonly seen is something called as the compression lows. So when somebody sleeps, for example, if you have a sensor on the arm and you sleep on that arm, the sensor is not able to read your blood glucose, so it can give rise to, false low blood sugars. So I always tell patients, if in the middle of the night, thankfully the non-prescription CGMs don't alert, but for the diabetic, if it alerts and you're sleeping on that side, make sure you do a finger stick because that likely would be a compression low. And then if you have dehydration, that can impact the interstitial blood, the volume of the fluid, so that can give rise to usually low readings for the most part. And then if you have a faulty sensor, like sometimes you see it, there's a bad batch of sensors from the manufacturer. So when in doubt, always do a finger stick so you make sure and trust the finger stick. Yes. Correct. The question is, can dehydration affect blood sugar? So yes, dehydration can affect, give rise to false low readings. So when do you check a blood glucose? So you should check a blood glucose when in doubt. So do a finger stick. If the readings are not making sense to you, then always trust the finger stick. Patients who are on dialysis, usually the CGMs are off-label indications. I have a lot of patients who are a dialysis patient still use a CGM because they still see benefit from it. But I always tell them, make sure you check a finger stick because they get dialysis, they have fluid overload, sometimes underload, so that varies the interstitial blood volume so that your continuous glucose monitor readings might not be totally accurate. And then obviously we spoke about interfering substances like vitamin C. And then I have already spoken about the lag time. There is a lag of 15 to 25 minutes between the CGM and the finger stick, and finger stick is the more accurate. So CGM will catch up with this reading in 20 minutes or so. So this is time in range. So whenever you look at a CGM data, even in your phone, when you have these non-prescription CGM like Stelo and Lingo, you'll see a target range. So this is primarily for our diabetic population. The target range is set at 70 to 180, but for normal individuals or pre-diabetics, I prefer that range between 70 to 140, not 180. You should be around 95 to 100% of the time between 70 to 140. And if you're not, then, as I'll explain later on, there are the reasons why that happens and what we can do to prevent. And then in the report, you can also look at the GMI, which is the glucose management indicator, which gives you the estimated A1C based on how your blood sugars are running. So that's an added feature you can look at. So now the question comes, what can we learn from CGM data of healthy individuals? Like, if we wear this device, what is the learning here? So first of all, why would any healthy individual choose CGM, right? So if somebody is curious, they want to know how their blood sugars are doing, they'll try a CGM. Somebody who's already a pre-diabetic and they want to see how their blood sugars run throughout day and night could be a candidate. And then I think the most important part I want to focus on is to check for something called as glycemic variability, which is the trends of having high blood sugars and low blood sugars. And the highs are usually post-meals. So glycemic variability, as I'll talk about, is one of the biggest predictors for insulin resistance. So if you have a spike, then you need to be aware what you can do to avoid that. So glycemic variability is the big takeaway from here. So for example, if a patient has a normal A1C of 5.3, right? So we're talking about the prevention, but do we have any data which supports increasing health risks for blood sugars that are in the normal range, right? So we say, okay, if we are preventing this, is there added benefit we are getting for the long term? And yes, the answer is there is. So there is data which shows that if you have a fasting blood glucose, even above 87, there is risk of developing diabetes increases. Why? And mostly that is because your post-meal blood sugars are high. If A1C above 5, the risk of heart diseases increases progressively. And if you have a blood sugar which is above 200 post-meal, that might be an important indicator for heart disease and mortality risk, even if your fasting blood glucose is normal. So the post-meal blood sugar is the main thing we want to look at and target. So I just wanted to briefly go over studies. So this one study was done at Kaiser. They followed patients for 10 years. And they saw that with each 1 milligram deciliter increase in the fasting glucose, the risk of diabetes increased by 6%. And if they had their fasting blood glucose between 95 to 99, the risk was 2.3 times more, even if the fasting glucose was below 85. And if the fasting glucose, I meant was if the glucose is 95 to 99, the risk is 2 times more. If it's between 90 to 94, they are 49% more likely to develop diabetes. So basically, this shows that as the fasting glucose increases above 85 to 87, the risk increases. So we have data which says that. This is another study which then looks at the 2-hour glucose. So the postprandial or the 2-hour glucose has been shown to be a measure predictive of mortality and coronary artery disease. And this study is a European study they did where they saw that anybody who had a 2-hour glucose above 200 had 100% higher risk of all-cause mortality, 50% higher risk of cardiovascular disease, even when they had a normal fasting blood glucose. So technically, I think what we should look at when we're talking about prevention is the postprandial or the post-meal elevation in blood sugars, because you could have a normal A1C, normal fasting glucose, but still have insulin resistance. So as I said, patients can choose CGM to assess postprandial glucose. So necessarily, even if they have a normal fasting, they can use this device then to look at the post-meal hyperglycemia. So does glycemic variability matter in non-diabetics? Because we are talking about the spikes post-meal, but does it really matter? So yes. So your A1C is basically a measure of blood glucose for the last 3 months, right? So if you want to look at the short-term, day-to-day, hourly blood glucose, that's where your CGM comes into view. And what I want to focus on is the time and range, which I mentioned. The MAGE, the mean amplitude of glycemic excursion, is a little more complicated, so I don't want to confuse everybody. But basically, if your time and range is between 95 to 100% within your 70 to less than 140, then you don't have to worry. You are fine, your glycemic variability is not of concern. But if that percentage is higher, then we need to tease out the data when you're going high, what is causing that. So this basically graph shows that what glycemic variability looks like on a CGM, right? So the bottom one is a patient who has type 2 diabetes, and you see a lot of peaks, and so the graph is like this, right? But the topmost is the healthy individual, where you see that there is very less variation. So what we want to target is the top. We avoid excursions, because you don't want to have too many peaks after meals, especially. So this is, again, some data, if somebody's interested, to look at, which basically shows glycemic variabilities as increased risk for cardiovascular disease, mortality, and even complications from long term. So this data was studied for 30 decades, actually, and in younger individuals who were between 25 to 30 years of age. And they found that if they had glycemic variability, they had higher instances of having cognitive dysfunction or decline as they grew older. So we have documented data showing how important glycemic variability is to target if you're trying to avoid or talk about the prevention aspect. Okay, so how accurate are CGMs? As I've already spoken, there is a difference of 8 to 10% between the finger stick and the CGM, so we have to keep that in mind. There's a lag time. I've already spoken about the other aspects. Now, it's important when you have a blood glucose below 70, if you're a healthy individual, those are most likely false low blood sugars. So if you ever have that, I always recommend doing a finger stick to check. So what is the cause for the postprandial hyperglycemia in non-diabetics, right? So multiple things. If you're overweight, you're obese, that's one risk factor. If you don't sleep well, you're chronically stressed, another risk factor. Stress releases cortisol, catecholamines. Those hormones are known to cause elevated blood sugars. If you're not physically active, more sedentary, another risk factor. And then if you have medications, like if you're on a beta blocker for hypertension or statin for cholesterol, There is a risk, but again, you have to weigh the risk versus the benefit, because if you have high cholesterol, you don't want to get a heart attack, then you should be on a statin, so always weigh the risk and the benefit. There is some data on even caffeine, although I'm guilty of drinking caffeine, so can't really practice that, or preach that, sorry. Okay, what are the other factors? Then diet. Diet is major, major, major. So if you're eating a lot of processed foods, white bread, white pasta, it's like they are known as zero, like simple carbs, they're going to spike your blood sugars. So that's something to keep in mind is major. And then there are some patients who are more, or some people who are more prone for insulin resistance after dinner. Their blood sugars run high after dinner, and it's likely related to some hormonal imbalance they have, which is individual to them. But I always advise all my patients, I always say, make sure ideally you give a gap of 4 hours from dinner time to bedtime, so that because we are more sedentary at the end of the day, you want to make sure there's enough time for the food to be digested. And then your dinner should be primarily more so protein and healthy fat and less carbs, because you're not moving around as much unless you decide to go for a walk post-dinner. And then gut microbiome. This is something which is not talked about enough. But the gut is like major, because you have certain microbiomes which release butyrate. And if you don't have the right microbiome, it impacts your glucose levels, even your cholesterol and lipid levels. And that's another topic which I don't want to get into because I can talk about it. But gut is major. Okay, so glucose response to food is highly individual. So every patient is different, every person is different, and that is why one of the reasons we have to keep in mind, it is good to have a tool like CGM, because then you can see your real-time data and compare if you want. So this is in summary what I would want to emphasize is CGM can be used to optimize your physical and mental health, because you have more data points, you can do the prevention. And diabetes and coronary artery disease risk increases even with normal blood glucose range. So it's important to look for the postprandial glucose, and if it is above 200, even if your fasting blood glucose is normal, you want to make sure you avoid that target to have those less than 200, or actually less than 140. So you want to avoid those postprandial peaks. And you can use the CGM to sort of see where you're going high, what you can cut back on. And then glycemic variability is the early indicator of insulin and glucose dysregulation, so you want to make sure you avoid those peaks. Again, can't emphasize enough, below 140 after meals. You want to remain in that target range, 70 to 140, 95 to 100% of the time. It's important to know that if when in doubt, do a finger stick, because there is a difference of around 8 to 10%. And then every person has, high variability response to different food items, which is genetic, many other factors. And high glycemic index diet is one of, again, the most important risk factor for the post-meal blood glucose. So we talk about the glycemic index when we talk about the diabetic diet, right? So you want to make sure you choose the foods which have a glycemic index less than 45, ideally, because anything above 70 is not good. And then our educators are there to guide you more about that. And then, I've really found CGM really beneficial for a lot of my overweight, obese patients, because when you use this device, they just look at their blood sugar, they're seeing what food is doing. It makes them so much more aware. It sort of motivates you to change your lifestyle or change your eating habits. Like if somebody decides to have 3 slices of pizza and their glucose goes to 200, next time around, they want to probably cut back and have 1 slice and see what that does, right? So it gives you a lot of information to work with, and then when you start making those changes and you're seeing the real-time data, you're seeing the benefits, it just motivates you to then exercise, and this is how, prevention can be totally achieved is when we have real-time data. And then I wanted to invite Kelly, who's our manager for the Braden Diabetes Center. We have our excellent team of certified nutritionists, educators, dietitians, who are really passionate about the diabetes, and also we are focusing a lot on the prevention aspect of diabetes. So you have this tool in the community to see members from our team. and she'll go over the details of what all we offer. Thank you. Want to go there? One second. Yes.
Are we on now? Yeah, okay, thanks. So thank you very much, Dr. Sadhu. My name's Kelly Stroop. I manage the Brain Diabetes Center, Marin Health's Brain Diabetes Center. Dr. Sadhu gave a thorough review of prediabetes, and there is so much information. So what do you do now with all of this education and information? So the Brain Diabetes Center is part of Marin Health. We offer a large majority of our services are for patients with diabetes, type 2 and type 1 diabetes, but we do have offerings for patients who don't have diabetes. So we do meet with a lot of patients who wear a Stelo or a Lingo and go over that education with them. We look at the data with them so you can see what that glucose is doing after eating. You can meet with a dietitian that can go over really individualized meal plan and education for you, so you can learn more individually what might work for you. And then, of course, we see a lot of patients also for, listed up here, insulin pump training and teaching, this continuous glucose monitoring for professional and personal. If you are interested, please leave on your form, or you can Google the Brain Diabetes Center. A referral from your doctor is required, so talk to your provider about your interest. Go online and order one of those non-prescription continuous glucose monitors, and then give us a call also. We'd be happy to meet with you, discuss individualized care for your interest, and answer questions that you have. Thanks.
We'll now take this opportunity to open it up to questions. If anybody has questions either for Kelly or Dr. Sadhu, we'll just walk around. Let me start in the back of the room.
Hi, thanks for your presentation. I've been told that 2 hours after eating a meal is the opportune time to do a check, and I was wondering if you have a comment about that, or I'm always inclined to check it sooner than that because I'm kind of anxious, but does it peak 2 hours after you've eaten, like, say, dinner, or what's your suggestion on checking after eating?
So, 2 hours after, as I was just mentioned in my talk, 2 hours after meal is really important because that will tell you if you have postprandial hyperglycemia. So for my diabetics, I always tell them, you want to make sure your 2 hours after meals is below 180. That's the target for diabetics. But if you're a healthy individual, if you have prediabetes, I would say that number should not go above 140. You ideally want to remain below 140. 2 hours after, yeah.
Great. I think we had some other questions. Hang on.
Hello. Thank you very much. That was a lot of information to absorb.
Yes.
I have my annual checkup results have been pre-diabetes for many, many years, sort of borderline. My cardiologist, who prescribed 5 milligrams of Crestor, rosuvastatin, had me go to Braden and do the 2-week protocol. And as far as I can figure out, everything's fine. So what is going on?
I think that in order for me to comment, I would have to look at your data.
Yeah.
So if your target range, so that is 70 to 180. That report is 70 to 180 if you look at the target range. So that is for diabetics. For non-diabetics and pre-diabetics, I say I target 70 to 140. Yeah, I can take a look at it. So technically, if your post-meal after meals is going above 140, then there is scope for working towards reducing that glycemic variability, even if you're a pre-diabetic. Yes.
Thank you very much, Doctor. Appreciate your very fine presentation.
Thank you.
I have had type 2 diabetes for 15 years, and I used to go to a support group over at the Braden Diabetic Center. But I take Ozempic, and it's being heavily advertised, and more people are taking it for weight loss management. Do you feel that the Ozempic or that category of drugs is really helpful in maintaining an A1C? For me, it's right about 7.0. So what about these Ozempic type of drugs?
Great question. So Ozempic is FDA approved for type 2 diabetes. If you're looking at the weight loss component, the FDA approval for those drugs is Saxenda, Wegovy, or Zepbound, which is the most recent one. So there has been a lot of noise on the weight loss drugs because a lot of celebrities, tech moguls have taken and they've lost drastic amount of weight. So I always say this, these medications are extremely beneficial, but they need to be used in conjunction with lifestyle changes. So if you're somebody who've tried everything, you exercise, you watch what you eat, and I have a lot of female patients, who've tried everything, they're unable to lose weight, and they are overweight and obese. So these medications absolutely can bring down your blood sugars because they have multiple mechanisms of action. So they reduce your satiety, your hunger satiety, so you tend to eat smaller portion sizes. But it's not only that, there is reduced glucose reabsorption from the liver, decreased glycogen production, which is a hormone from the liver. So a lot of aspects, and it also impacts your hunger centers in the brain. So there's multiple mechanisms of action where it is not only having you reduce your appetite, but also decreasing your blood glucose through other various mechanisms. So patients lose weight when there is weight loss. They're more motivated to work out, they're eating healthy, and that reduces your A1C and other, like blood pressure, cholesterol. It's important to know that when you're losing weight, 50% of that loss is muscle. So what we are now seeing is that if you're not exercising or doing strength training at least for 4 or 5 days a week, and you're not consuming enough protein in your diet, once that muscle is lost, your muscle is where your metabolism is. So a lot of these patients, when they stop these drugs, they not only gain it back, they gain even more. Why? Because that muscle metabolism is gone, because you were not monitoring, you were not exercising, you were not doing strength training, you were not having enough protein in the diet. So it's important that when you use these drugs, they are absolutely beneficial, miraculous for a lot of patients, but to do it with lifestyle changes.
Mostly have to be authorized by your physician and get special authorization, and they still are very expensive.
Right. So unfortunately, the insurance is drive, which frustrates the hell out of me. But we have a new indication. So if you have an obstructive sleep apnea and you're obese, you could get it authorized through your insurance. And you have to be careful about compounded pharmacies. There are a lot of online pharmacies which will tell you, you pay $100 and we'll ship you Ozempic and all these drugs, because they are not FDA regulated. We don't know about the accuracies, the safety of these medications. Some of these patients are on these compounded drugs. They end up having severe side effects. Bowel obstruction was one of them. So Novo Nordisk, who's one of the pharmas for these weight loss companies, sued one of the compounded pharmacies because they were just, when a compounded pharmacy makes a drug, they use a lot of stabilizing agents for that medication, which there is no accuracies by the FDA. So they cause side effects. So you just have to be very careful. See a licensed practitioner who's prescribing you these medications appropriately and in the right dose and the right increment. You shouldn't be incrementing or going up on the dose too quickly, because that also is another issue I see all the time. So somebody who's experienced to use these medications.
You have a question over here?
Yeah, please. What is type 1 diabetes? You never hear about it. You hear pre-diabetic and type 2. So just curious. I see it's up on the screen now, but...
Yeah. So type 1 diabetes is basically autoimmune. It's usually where your pancreas don't make any insulin at all. So most common cause is autoimmune. You have antibodies which have attacked your pancreas, your beta cells which produce insulin, and they're destroyed. So there is no insulin production. So you're insulin dependent for life. So that's an autoimmune condition. So prevention of that is like autoimmune can happen to anybody, right? So that's the difference. Whereas type 2 diabetes, you have your pancreas, they're intact, they're producing insulin. It's just your tissues are resistant to the action of insulin, so we can prevent. So that's the difference.
I have two questions.
Yes.
First, the goal for diabetic control is 70% in the green zone. Yeah.
So that what I showed you was just a screenshot of what a type for a diabetic a CGM looks like. If you're a diabetic, you should have your range is 70 to 180. And for me, because I am a little more strict endocrinologist, I would say I target my patients to if they can have 90% and above in that range for me, because then you look at to avoid the peaks and the troughs, right? And then I talk to them, okay, what can we do so we bring the target range 90% and above? If you're a non-diabetic, you're a pre-diabetic or a healthy individual, that range should be 70 to 140, and you should be 95 to 100% within the 70 to 140 range, ideally.
So my question is whether there's any data to show that there's improved prognosis if you're in the 100% in the green zone versus 70%, or is 70% arbitrary?
No, there is data. So if your numbers are higher, you have increased risk of cardiovascular disease, coronary artery disease, all-risk mortality, micro and macrovascular complications. So there is definitely data, and even cognitive decline if you have those numbers which are higher and you have more glycemic variability.
Okay. My second question relates to that diabetics have two things in common. They have insulin resistance, and they have beta cells that don't produce insulin. What's the relationship between these two, and what's the mechanism by which the pancreatic beta cells no longer produce the insulin?
So I sort of want to use this. Let me see if I can go back, because I don't think I can go back. But I had a slide in the beginning. In the initial slides I had shown, so basically when you have that graph I had shown is your beta cells produce insulin, right? So when you have insulin resistance, your beta cells are trying to work harder to maintain your blood glucose, right? So as the insulin resistance rises, your beta cells are working harder and harder and harder and harder, and then finally you develop prediabetes, because if you're not doing the right measures, it's still fighting. So then they reach a peak where they become fatigued, so they no longer can keep up with your glucose level. So that's where you develop prediabetes, right? And if somebody's had uncontrolled diabetes, like for 20 years or so, the beta cells are still working, but the tissues, because they have insulin resistance, because the tissues are resistant, they finally reach a point where they burn out. So you will see, I see it a lot of times when you have uncontrolled type 2 diabetes for decades, you become insulin dependent at certain point if you don't control your numbers, because your beta cells are all fried. Like they've been working over hard. Towards the end, it's just like the function is totally gone. So that's the reason if you want to maintain beta cell function, because you cannot, once you lose it, you can't regain it, it's important to avoid those glucose spikes.
So all diabetics have insulin resistance?
All type 2s, yes.
Just one second, let me get this side first.
Thank you. I also have a question about the B cells. So B cell can also be diagnosed in non-Hodgkin's lymphoma with a B cell subcategory. And are these the same beta functioning or different, because if you have that and it's treated, it doesn't affect this insulin production?
So B cells are totally different. That is part of your immune mechanism. The beta cells are part of the pancreas, and they are just responsible for releasing insulin. So that's totally separate.
Can you hear me? I'm a former athlete, and also my younger son is now 32, and he was a former athlete. How is the obesity index determined? Because there's a lot of muscle mass, and so it's not just determined by weight. So how do you get a baseline? How do you figure out what's the blood sugar level for a prior athlete?
Great question. So you could do something called as body composition. There are devices where you stand on them, and they're able to give you your weight, your BMI, your muscle mass, your fat content. That's one tool to use if to know. But I think I have some athlete patients who wear continuous glucose monitors if they're looking at, Because some of them, like those who are doing ultra marathons or triathlons, versus somebody who lifts weight or is into weightlifting, the CGM is really great because if you're doing any aerobic exercise where your heart rate is high, you will see the blood sugars will be more lower. If you're doing anaerobic, like lifting weights, there's release of hormone called as glycogen from the liver, which can sometimes raise your blood glucose, but that is only temporarily. So I think a CGM is a great tool because some of the athletes, they eat a really carb-heavy meal like before they need to go on a race, right? Because they're going to burn all that out if they're like, for example, if they're cycling for an hour, right? So I think a tool like CGM can be used because then you're looking at, even if you eat a carb-heavy meal, but you're going to exercise right after, you still shouldn't see that spike, right? Because you're going to burn it off. So if you look at the data points from glucose perspective, CGM is a great tool. But if you want to look at how much, I weigh like 200 pounds, but if major component of that is muscle mass, and you have less fat and you don't have any glucose spike excursions, you should be fine. Yeah.
We have one question on this side.
Yes.
Just again, what's like the average cost for a monitor?
For the CGM?
Yeah.
Yeah. So the Stelo by Dexcom is $89 for 1 month. They have 2 sensors, each last 15 days. So if you enroll into their monthly program, it's $89. If you just want to use it for a month, it's like $99 per month. And it's similar for Lingo and Stelos.
Any other questions? I'm going to...
Moving to the thyroid, which you haven't discussed, are you still opposed to prescribing Armour thyroid?
Oh, that's off. Yes, so Armour I don't prescribe. Why? Because Armour is made out of usually pig's thyroid gland or its natural source. They dry it out. It's important to understand thyroid produces 2 kinds of hormones, T4 and T3. And the T4-T3 ratio has to be in a certain amount, which is 16:1 to 13:1. So if you don't use the T3 appropriately, you could have side effects, primarily arrhythmias of the heart and promotes accelerated bone loss, which can promote osteoporosis. So Armour or Nature Thyroid is not FDA regulated. I do not know if I prescribe how much T4 and T3 I'm giving you. So for those reasons, I steer away from prescribing. I do T4, T3 combination for a lot of my patients, but then I know what ratio I'm giving. So that is the reason for not doing Armour.
Great. Any other questions? Great. Well, I'd like to, first of all, let's all give Dr. Sadhu and Kelly a round of applause.
Thank you.